Uh, Welcome everyone. Common congenital disorders of the lungs. It will be the second lecture of our lectures, and we have another two lectures, inshallah, presented by me, Dr. Ahmed Ibraheem, Assistant Professor and Consultant Cardiothoracic Vascular Surgeon. Just to remind you about the anatomy, we have upper airway and we have lower airway. The upper airway consists of nose, nasopharynx, oropharynx, laryngopharynx, and larynx. Lower airway, trachea, and lungs. Tracheobronchial abnormalities include tracheal agenesis, tracheal stenosis, tracheomalacia, tracheoesophageal fistula, and bronchial atresia, tracheal bronchus. Pulmonary underdevelopment, we have lung agenesis, we have lobar underdevelopment, and scimitar syndrome. Bronchopulmonary foregut malformation, bronchogenic cyst, enteric cyst, neuroenteric cyst, and congenital cystic adenomatoid malformation, and pulmonary sequestration. The gross anatomy of the lungs include on the medial aspect surface of the right lung, you have pulmonary arteries, we have pulmonary veins, we have hilum, we have primary bronchus and horizontal fissure and oblique fissure. So on the right side we have three lobes. On the left lung we have pulmonary arteries, primary bronchus, hilus, and or hilum, and pulmonary vein, oblique fissure. So we have two lobes. Regarding the bronchi and lobules of the lung, we have trachea and right left main bronchus, and we have primary bronchus, secondary bronchus, tertiary bronchus, and smaller bronchiole till we reach the alveoli and pulmonary bronchioles. Tracheal agenesis is absence of growth in trachea or in part of it. Male to female ratio 2:1, often incompatible with life. Tracheomalacia causes tracheal wall softening due to an abnormality of the cartilaginous ring and hypotonia of the myoelastic elements. Primary tracheomalacia congenital, immaturity of the tracheal cartilage. Secondary tracheomalacia, which is previously normal cartilage, undergoes degeneration. Tracheomalacia commonly involves most of the tracheal and other major airways. Symptoms: expiratory stridor. It may worsen with supine position, crying, and respiratory infection. Congenital diffuse malacia of the airway improves by age of 6 to 12 months as the structural integrity of the trachea is restored gradually. Acquired tracheomalacia, prolonged endotracheal intubation, relapsing polychondritis. Fluoroscopy shows an exaggerated decrease in the caliber of the trachea during expiration. In this X-ray, you can see how the trachea appear. In case of tracheomalacia, this is a 2-month-old infant with stridor, marked diffuse tracheal narrowing during expiration. Tracheal stenosis cause focal or diffuse complete tracheal cartilage rings, resulting in a fixed tracheal narrowing. Most common combined abnormality, pulmonary artery sling complex. Tracheal stenosis, 50% focal ring-like, 30% generalized, 20% funnel-shaped. And narrowing of the tracheal lumen in the subglottic trachea is shown by this X-ray as a rod. Tracheoesophageal fistula, epidemiology, incidence is 1 to 4,000 population. 30 to 50% congenital anomalies, 35 associated anomalies, 35% cardiac, 30% musculoskeletal. Bacterial and Vater syndrome include vertebral anomalies, imperforated anus, cardiac VSD, PDA, tetralogy of fallot, coarctation of aorta, ASD, trachea, tracheoesophageal fistula, esophageal stenosis, and renal agenesis. These are the types of tracheoesophageal fistula. I have another slide more clear. Here we have type A. In type A, there is esophageal atresia without tracheoesophageal fistula, and it consists 8% or forms 8% of cases. Type B, the esophageal atresia associated with proximal tracheoesophageal fistula and occur in 1% of population. Type C, esophageal atresia proximal with distal tracheoesophageal fistula, and it is the commonest type, 84% of cases. Type D, proximal and distal fistula, tracheoesophageal fistula, 3% of cases. Type E, which is H type, there is no atresia, but there is an tracheoesophageal fistula. Diagnosis. During pregnancy, maternal polyhydramnios, and premature labor. For the newborn, signs, symptoms: cough, choking, cyanosis, excessive salivation, drawing of saliva, nasogastric tube. When you insert a nasogastric tube, it cannot pass down to the stomach. By X-ray, you can see the angiotube either curled up in the upper pouch of the esophagus, and there is air gas bubble in the stomach and intestine. Ultrasonography is helpful in diagnosis. As you see here, tracheoesophageal fistula, the proximal part of the esophagus there is atresia, and you see the nasogastric tube is looped and go up, not passing to the stomach. Management of tracheoesophageal fistula. Primary repair of the tracheoesophageal fistula is urgent. Associated anomalies: cardiovascular, musculoskeletal. Protect the lungs from aspiration pneumonia is very important by avoiding feeding, positioning of the infant slightly head up to minimize regurg of gastric contents through the fistula. Intermittent suction, antibiotic therapy, and physiotherapy in babies with contaminated lungs. Surgical management: one-stage repair which is the optimal surgical management. The fistula is ligated. Proximal and distal ends of the esophagus are anastomosed, and the approach is through the right posterolateral extrapleural thoracotomy, and left thoracotomy may be used in cases of right aortic arch. Gastrostomy may be used in high-risk patients till they can withstand thoracotomy and anesthesia. So definitive repair within the first 24 to 72 hours when infant can withstand both surgery and anesthesia through right thoracotomy using a posterolateral extrapleural approach, and fistula is ligated, esophageal segments are anastomosed together. Bronchogenic cyst, a result of abnormal budding of tracheobronchial tree during 26th day to 16th week of intrauterine life, in which a trachea or bronchial bud becomes detached from its parent, thereafter developing separately to produce a cystic structure. Thus, it is anomaly of ventral foregut and lung budding in the first trimester. It's common in male. Bronchogenic cyst as a classification, we have central, mediastinal 75 up to 85%, and male to female 1 to equal the percentage. Usually asymptomatic. Stridor dysphagia may be the symptom. Location posterior mediastinum, 50% pericarinal, 30%, and superior mediastinum 40%, usually on the right. Peripheral, intraparenchymal, 15 to 25%. Development and anomaly arise at later stage. Male to female ratio is 2 to 1. Usually medial third. Infection 75%. Dyspnea and hemoptysis may be symptoms. Bronchogenic cyst cause chest pain, dysphagia in adults. In infants, symptoms from airway or esophageal compression. Recurrent pulmonary infection due to bronchial compression. Symptomatic patient more likely to have perioperative difficulty. Rupture of the cyst causing mucopurulent cough or hemoptysis. Complication, infection, rupture, bleeding, adenosarcoma, compression of the airway. Radiologically, chest X-ray and CT is more specific. Well circumscribed, rounded, homogeneous opacity, situated either in the mediastinum, close to major airway, or in the lung periphery. CT shows water density 50% higher density, 50% on CT, about 50% shows density more than water due to increased protein content. Air fluid level may not be seen. Barium swallow may detect the esophageal compression. Treatment, elective surgical resection. Aspiration may be considered in patients who are symptomatic and unfit for surgery. And examples for bronchogenic cyst. This is chest X-ray showing right-sided upper zone mass, and by CT it shows water density, well-defined water density, homogeneous mass with no contrast enhancement. Another case with a ruptured with air fluid level accompanying the entire right middle lobe. CT scan, thick walled fluid level rounded mass with an air fluid level corresponding to the infected bronchogenic cyst. Another examples: congenital adenomatoid malformation of the lungs. It may involve either a part or whole of the lobe, or rarely an entire lung. The vascular supply from pulmonary circulation, and pathologically it's firm airless mass of disorganized tissue that lacks properly defined bronchial system, but contains an excess of air passages resembling terminal bronchioles, and often include mucus cysts of varying sizes. Classification: we have type 1 variable sizes cysts with at least one dominant cyst more than 2 cm. Type 2, smaller, more uniform cysts less than 2 cm in diameter. And type 3, solid mass composed of bronchoalveolar microcysts. Congenital cystic adenomatoid malformation type 1. This is an example showing multi-cystic lesions. Right hemithorax, variable size of the cysts, some of them more than 2 cm. And another patient with type 1 showing the bubbly mass in the left upper lobe with a dominant air cyst more than 4 cm in diameter. Another patient with type 2 affecting the left lung, displacing the mediastinal structure to the right. And this is type 3, congenital cystic adenomatoid malformation, irregular microcystic mass affecting the left lung and displacing the mediastinum to the right, often causes death at birth. Symptoms: neonatal respiratory distress and compromise, including tachycardia, retraction, and cyanosis. Older children, recurrent pulmonary infections usually involves a single lobe. Symptoms: 50% premature birth, 25% stillbirth, may die within a few hours or of birth with anasarca caused by vena cava compression due to space occupying lesion affecting effect of a tissue mass, complication, infection, and pneumothorax. Radiologically, it appear like multiple air-filled thin-walled cysts with variable size, air fluid level, superimposed infection, and hyper-expanded lung. Differential diagnosis: necrotizing pneumonia, recurrent infection in the same site. Diagnosis: antenatal sonography, chest X-ray, CT, treatment by surgical resection. Anomalies of the lung parenchyma: pulmonary underdevelopment, agenesis, aplasia, and hypoplasia, congenital abnormality of lobulation like a zygous lobe, and lung sequestration. Underdevelopment: either agenesis, one or both lungs are completely absent, or aplasia, in which all but a rudimentary bronchial bronchus that ends in a blind pouch is suppressed with no evidence of pulmonary vasculature or parenchyma. Hypoplasia, gross morphology of the lung is essentially unremarkable. Pulmonary agenesis occur during the embryonic period, approximately 4 weeks gestation, etiology unknown, usually unilateral. More than 50% with associated of cases associated with congenital anomalies, cardiovascular and gastrointestinal. Pulmonary agenesis, as in this photo, there is complete absence of a lung, or right in this patient, right lung. Agenesis have a shorter life expectancy than those with left lung agenesis. And radiographically, chest X-ray shows a small, completely opaque hemithorax with displacements of the mediastinal structure and diaphragm. This is an right lung agenesis. Right lung agenesis again. Another case. Here, agenesis may be confined to one lobe, most frequently the left upper lobe, as in this patient. Pulmonary hypoplasia, most common cause, congenital diaphragmatic hernia associated with congenital diaphragmatic hernia. Others, extralobar sequestration, large pleural effusion, decreased pulmonary vascular perfusion, and so on. Symptoms: early respiratory distress after birth, cyanosis, tachycardia, hypoxia, hypercapnia, and acidosis. Pneumothorax and pulmonary hypertension are common serious complications. Radiologically, there is decreased aeration of the affected hemithorax, more frequent in the right lung, and a small thoracic cage. As you see, there is opacification of the left hemithorax, and small left lung is shown with ipsilateral displacements of mediastinum secondary to repaired Bogdalic hernia. Pulmonary hypoplasia, X-ray of a patient. By aplasia by CT shows the rudimentary bronchus as well as absence of ipsilateral pulmonary artery. Hypoplasia by CT, patent bronchus, pulmonary artery, and hypoplastic lung, and bronchoscopy may be used for diagnosis. Definition: pulmonary sequestration. Definition: pulmonary malformation in which a portion of the lung parenchyma is detached from the remaining normal lung and receives its blood supply via a systemic artery. Types: intralobar and extralobar. Intralobar and extralobar, two types of pulmonary sequestration. Pathogenesis: pulmonary sequestration develops due to formation of an accessory lung bud distal to normal laryngotracheal bud on the ventral aspect of the primitive foregut. Accordingly, that arise in close proximity to laryngobronchial bud may become incorporated into it during its development to become intralobar sequestration. And second, that arise from the foregut more distally, either from the proximal part of the stomach escape development and become extralobar sequestration. Intralobar, two-thirds of the cases, sequestered lung is situated in posterior-basal segment of the left lower lobe, and abnormal tissue grossly. It is abnormal tissue, well defined from surrounding, well demarcated from surrounding lung parenchyma. Vascularity, arterial supplies from aorta or one of its branches. Venous drainages into pulmonary venous system. Extralobar related to the left hemidiaphragm in 90% of cases. Maybe in between the inferior surface of lower lobe and diaphragm, below diaphragm, or within the substance of diaphragm. Morphology completely enclosed in pleural sac, and within the lung, regarding the intralobar, has visceral pleural covering, or diagnosed in older children and adults, usually considered an acquired abnormality, usually contains air within cystic lung tissue or air fluid levels when infection are present. Extralobar is abnormal lung tissue surrounded by its own separate pleura, occur in neonate, male to female ratio 4:1, arterial supply from their thoracic aorta or abdominal aorta, venous return into the IVC zygous vein or portal vein, associated anomalies in 60%, 65% diaphragmatic hernia, congenital heart disease, pulmonary hypoplasia. Symptoms: asymptomatic, recurrent lower lobe pneumonia may be a symptom. X-ray shows soft tissue opacity in the posterior basal segment of the lung with smooth or lobulated margins. CT MRI are helpful in the diagnosis. Retrograde thoracic aortography is sometimes done to demonstrate its blood supply. This is an examples of pulmonary sequestration. Here you see the blood supply coming from the aorta. Treatment of pulmonary sequestration: resection of symptomatic pulmonary sequestration is indicated, and infection usually treated by antibiotic. Intralobar sequestration usually requires segmental resection. Lobectomy. Extralobar sequestration may resect the sequestrated part without disturbing normal lung. Azygous lobe, one of the most frequently encountered. The bronchial anatomy remains intact, and the presence of azygous lobe carries no morbidity. Shown by X-ray and by CT, it's the medial portion of a bifurcated right upper lobe, and in human may be regarded as an anatomical variation. During development, if the apex of the right lung is, as it enlarges, encounters the zygous vein and SVC, so there will be an arch over the root of right lung to join the SVC. It will arch there and cause a zygous lobe. By X-ray, the fissure shows thin outward convex. line ending in a small triangular shadow at its lower end. So this is the zygous lobe, and by CT it looks like this. Congenital lobar emphysema is a progressive overdistension of a lobe, sometimes two lobes, cause a check valve mechanism at the bronchial level that causes a progressive hyperinflation of the lung by allowing more air to enter the involved area on inspiration than leaves on expiration. So this is a case of lobar emphysema. Lateral view shows an hyperlucent retrosternal area arose that corresponds to the lobar emphysema. Left upper lobe involved in about 45% of cases, right middle lobe in 30%, right upper lobe in 20%, two lobes in 5% of cases. Another patient with congenital lobar emphysema. Male affected more than female, may be associated with other anomalies. Type 1 becomes symptomatic in infancy and most common. Type 2 becomes symptomatic in older children. Type 3 an incidental finding. Respiratory distress is the most common symptom. Chest X-ray and CT shows hyperinflation of the segment or lobe affected. Congenital lobar emphysema, other photos. Anomalies of pulmonary vasculature, pulmonary AV malformation, anomalous pulmonary venous drainage, scimitar syndrome. Other absent pulmonary artery trunk, absent unilateral pulmonary artery stenosis. Scimitar is a syndrome is a veno-lobar syndrome, hypogenetic lung syndrome, a rare congenital cardiovascular anomaly involving the right lung. It's ipsilateral anomalous pulmonary drainage of parts or all of the right lung into the inferior vena cava. Hypoplasia of the right lung, dextrocardia, hypoplasia or other malformation of the right pulmonary artery, anomalous systemic arterial supply to the lower lobe of the right lung from the subdiaphragmatic aorta or its main branches. This is the scimitar syndrome, as you see the venous drainage of the right lung to the inferior vena cava. Scimitar syndrome as seen by the X-ray and of course need more investigation to reach the diagnosis. Three forms of scimitar syndrome. Infantile form, a large shunt between the abnormal artery that supplies the lower lobe of the right lung and the subdiaphragmatic aorta. Adult form, a small shunt between the right pulmonary veins and inferior vena cava. Third form, additional cardiac and extracardiac malformation. And thank you.